pleasure to introduce the next speaker, Andrew Allegretti. Andrew is a graduate of our program and has been on faculty for now 10 years at Mass General. He's world-renowned for his work in liver disease. I quote one of his papers in 2018 in JASN, probably 2 to 3 times on service, every consult service, as to the prognosis of dialysis requiring AKI and end-stage liver disease. And he'll talk, or has talked already, about liver disease and kidney disease. For today, he's going to be talking about ICU nephrology and continuous renal replacement therapies. Thank you, Andrew.
Thanks, Dr. Mount. Thanks, everyone, for having me back and for your continued attention. My introduction slide and disclosures remain the same. So ICU nephrology, I think, is a really fun and nuanced area of renal medicine. So you'll hear my approach to how I see consults in the ICU, and we'll spend some time talking about the nuances around renal replacement therapy in the ICU. I'd like to start with the study. It's an old one now. It's 20 years old, but has been replicated time and time again, just to remind ourselves how sick the patients we take care of in the ICU are. This is one of many nice epidemiologic studies citing that when you have a severe AKI in the ICU, your inpatient mortality approaches 60%. And while we're probably slightly better than that now in today's age, for a variety of different reasons, it's not that much better. It's still 50 plus. And the other interesting part of this study, and has been true of our clinical practice, is that if you have an AKID, dialysis requiring AKI in the ICU, and you make it to discharge, the chances that you require dialysis on discharge are really low, which makes this an interesting and complicated discussion when you're going over consent for CRRT, because the only 2 questions I really entertain, for the most part when I'm doing this myself, is when someone needs dialysis in the ICU is, will I survive? And will I be on dialysis for the rest of their life, my life, or their family's lives? And they don't mean if they're going to live 3 or 4 more days in the ICU, they mean if they recover and get better. And I'm not quite sure how to answer that with tact. And I can't say, no, you probably won't survive, but if you do, you'll probably not be on dialysis. But that is the basis from which we start this talk. So AKI in the ICU, the approach should be like any other AKI. I still use the old pre-renal, intrinsic renal, and post-renal, where, pre-renal, we're often not called as nephrologists for this because this gets better with fluids for the most part, although there's some situations like hepatorenal syndrome and cardiorenal syndrome, as well as some challenging vascular disease, macrovascular disease, that would technically be pre-renal, but not solved with fluids. And then post-renal, again, this is an outflow problem where all of your kidneys, if you have more than one, are blocked, usually relieved with a Foley, but sometimes more complicated. But because of the epidemiological nature of what we see in the ICU, most of the injury that we're consulted for, at least, is intrinsic renal, and that's largely ATN, either ischemic or nephrotoxic. We certainly can see interstitial nephritis in the ICU. In vascular cases, cholesterol emboli does occur and is hard to recognize. And then I put at the very bottom in small print, glomerulonephritis, which I won't talk about. I would say when I do an ICU block, maybe one case we're entertaining or diagnosing glomerulonephritis out of a block of 20 or 30 or 40. We do see pulmonary renal syndromes, but this is just lower on the list. But I do keep it on the list just to make sure we're not anchoring to everything is ATN. This has already been enumerated by Dr. Sheridan and others, the AKI definition system. This is the AKIN serum creatinine and urine output-based system, now updated at least in a draft form. I didn't want to put the KDIGO criteria that are being reviewed now, but will likely also include a cystatin C-based component and a biomarker component. So I'll talk a little bit more about the biomarkers in a moment. The pitfalls, of course, and again, this has been covered, so I'll move through it briskly, that there's limitations to serum creatinine, mostly around muscle mass. Cystatin C may help address some of those, as will perhaps injury biomarkers. And I won't belabor that. The workup that I do, it's probably the same as any other workup you should do, a history and a physical, looking for specific things like contrast and NSAID exposure, RAS inhibition, always reviewing operative flow sheets for signs of hypotension in the operating room that might not be apparent in the rest of the vital signs documentation. I almost routinely and always will call for things like a metabolic panel and a volume exam, look at the urinary sediment. Urine output is just as good as a vital sign. And I put not useful, not because, maybe with the exception of urine eosinophils, that they're bad tests. I just don't ask for them very frequently because I think they're confounded by too many things, specifically FeNA and Phe-urea in the ICU. I'm not routinely asking for it. Urine eosinophils have been largely debunked as a useful diagnostic test for interstitial nephritis, so I wouldn't send that one. And then the old BUN creatinine ratio to be indicative of prerenal if it's out of proportion. Too many confounders for BUN, steroids, and GI bleeding and such. I'll sometimes ask for a Spock protein ratio or a renal ultrasound, but not in every patient. Again, just briefly touching on the newer biomarkers, I think it's great that these are finally starting to work their way into clinical practice because creatinine is a late biomarker and does not reflect true tubular damage. This is particularly important in the ICU when you're trying to triage both fluids and whether you need a renal consult. Of course, cystatin C is approved, and while it does make an appearance in the draft KDIGO update that seems to be forthcoming as a definable component of AKI, meaning a 50% increase in cystatin C will define AKI, it doesn't have the same kinetics as creatinine does, and the staging system is not yet defined. Much better validated, obviously, in the CKD population. The tubular injury biomarkers are numerous, NGAL and KIM1 probably being the most well-known. There's no adult FDA approval for any of these. However, NGAL is approved for early detection of pediatric AKI, so it may be that you get it on formulary at your hospital before its adult approval. The adult studies are ongoing currently. And what is approved, but we don't have at our hospital, and I feel like never really got the larger uptake, is another tubular injury biomarker, this one of cell cycle arrest, and it's a combined biomarker, TIMP1 and IGF-BP7, commonly marketed as NephroCheck. These are FDA approved, these markers, as a early detection of AKI in the ICU. We don't have it at MGH or the Brigham, and I've found that many other sites don't either. I don't have a great explanation why, but they didn't really receive larger uptake. In terms of management goals in the ICU, of course, prevention is the best strategy for AKI. There's a couple of sort of niche studies that I don't have slides on about how to prevent cardiac surgery related AKI with preventative measures. I'll save that for perhaps a future lecture, but for now, it's the common sense supportive care stuff. You're trying to reverse the underlying insults. I think maintaining volume status is probably the most important thing we do in the ICU, as volume is so tightly related to outcomes. Hypervolemic patients do worse across basically every disease state. And then the big question that we get called for is when you need renal replacement therapy. And I generally hope that we get called before that, if for no other reason. It gives us a little time to get to know the clinical situation and the family and their patient and the patient and their family, so that we can sort of have a discussion about renal replacement therapy and not be thrown into it in the setting of a rapid hemodynamic collapse or a critical illness, although we don't always have that luxury. The AEIOU abbreviation for indication or classical indications for starting renal replacement therapy is still a good one. While it covers all the food groups of acidemia, electrolyte abnormalities, intoxication, overload, and uremia, it doesn't tell you at all when you need to start dialysis. So for that, it's not as useful. But again, we're trying to maintain fluid balance, clear life-threatening toxins, including potassium, as well as uremic complications. The most common uremic sort of indication for dialysis would be pericarditis. We sometimes will use things like DDAVP preoperatively to sort of liberate some platelets into the circulation, although the evidence behind that is somewhat mild. And I think of one word when I think about dialysis in the ICU, and that's what's the patient's trajectory? Is this something that's rapidly reversed and we can get through, or is this a long course ahead and then renal replacement therapy will enable that support? Just a brief word on access is increasingly nephrologists are not putting their own lines in anymore. And in fact, I don't think many programs in the country train it as part of their core nephrology fellowship. But generally speaking, you're looking for internal jugular access for dialysis. Right better than left, if only because it's a straight shot into the right atrium, and less torque and the less twisting of the lines, the better their function. Typical triage is right IJ, left IJ, then femoral, and then subclavian in terms of order you'd prefer. They run, commercial catheters tend to run anywhere between 11.5 and 12.5 French, with the larger catheters carrying a slightly increased risk of complications when you place them, but have better flows. Many places will place a catheter as a third port, the so-called VIP port for med infusion. I've not found that to be particularly helpful in the ICU, because usually you need more than one, and that line does take up valuable real estate inside the dialysis catheter and thus may interfere with flow. So I tend to not use them or recommend them, at least. And that generally we dwell citrate in these ports. So I always counsel teams not to push meds through them, not just because they're our lines and not their lines, but because if you're in a code situation and you push meds through a dialysis port and you haven't drawn off the citrate, you could get acutely hypocalcemic, which is not going to be helpful. There's been an evolution, I think, of the use of tunnel catheters in the ICU. When I was in training, there was a big push to get more patients in with directly into tunnel lines. This is logistically very difficult because these patients are often evolving quickly and on pressors or intubated or maybe have cultures brewing or septic. So in general, it's preferred to have a tunnel line, I think, in general for dialysis access because they tend to work better and they have lower infection risks, but tends not to be as practical in placing in an acute setting. When you think about numbers in terms of starting dialysis, if you go all the way back to dialysis's infancy in the 60s, you could use BUN as a rough estimate of uremia. And if you look at the early studies, the early versus late decision, when you looked at BUN level, seemed to favor early starts. However, that was in an era when you would let potentially a patient get up to a BUN of 200, which I don't think people would routinely do now. And you look at the more modern studies, or at least in the last 20 years, when you look at a BUN of 40 versus 60 or 100, it becomes a little more equivocal. And then there was this big flush about 5 to 10 years ago of studies that came out looking at this early versus late, and they all had somewhat similar criteria of when you would start renal replacement therapy in intensive care unit, with different levels of AKI, both mixed medical and surgical populations. The 3 New England Journal papers came to a same conclusion, which was that early versus late start had no effect on mortality. You did end up sparing some patients with the delayed strategy because some recovered on their own. Interestingly, the single center JAMA study, although it was statistically unstable, it was only sort of hovering around 1 patient switching groups to lose its p-value, so to speak, did show a survival benefit in the early group. Although if you look at this very nice summary from, I believe this is NephJC, it is NephJC's Journal Club, which have been doing a lot of nice work over the years. This Elaine study, which is the JAMA paper, has a very different criteria for starting renal replacement therapy in their study. So most of the other studies, you needed stage 3 AKI for the early criteria, and then this one you only needed stage 2, plus a positive NGAL. Interestingly, they used that, but they basically dialyzed everybody in the trial. Almost 95% of the people in the study got dialysis. I don't think that's a super practical approach with this early stage AKI. So the literature does support what I've been doing and what many people do, which is you are sort of empowered to do what's best for the patient. This is why I think the word trajectory matters. If you think you can skirt by with supportive care, you're empowered to do that, at least for some initial management strategies. But if you're starting to fall behind, there's certainly not a survival disadvantage to starting early renal replacement therapy. So again, it remains a clinical decision. There haven't been studies in a while looking at different modalities, meaning intermittent HD versus CRRT in terms of survival or outcomes. These are really hard studies to do. You obviously can't blind these trials. The last Cochrane review and meta-analyses have shown that there's no difference in outcomes, but I think we all sort of agree that if your patient is hemodynamically unstable on pressors and you're not achieving your volume goals with HD, you really should be thinking about a more prolonged strategy in order to do that. The cost is probably somewhat negligible, although at high volume centers, I think it doesn't make a huge difference, but in reality, it is a more expensive modality. I don't think we make a lot of decisions in the ICU, at least in Western medicine, based on finances, more critical illness related decisions, of course. This isn't an ICU study, but I do like to mention it because I think it's new and interesting. It may have been already talked about today. If that's the case, I apologize. But the Liberate-D study, which was a 4-center study done in the United States, looking at a more personalized approach to RRT frequency in floor patients, largely speaking. So if you're on pressors or intubated, you were excluded. But rather than doing a default 3 times a week, you would use a series of objective criteria to decide if this patient needed dialysis one day. And while it didn't meet statistical significance after adjustment, it did sort of hint at signals that the conservative or tailored strategy might have been a little bit better in terms of overall outcomes, at least from the primary outcome of the study. Whether that's true in the ICU, of course, remains to be seen, but it does speak to the fact that being personalized is probably a good idea in general for this population. The dose of renal replacement therapy, I feel like, has more or less been set in stone since the mid-2000s, where there were these 2 New England Journal trials that looked at replacement fluid rates of CRRT, standard versus what we would call standard now, of 20 to 25 mLs per kilogram, which you can see were the bounds used in the 2 different studies. and 35 to 40 mLs per kilogram, which if you take an 80 kilogram person multiplies out into about 1.6 to 2 liters an hour versus 3 or so liters per hour. There was no survival difference between the two, so in general we tend to start low and go up if your clearances are inadequate. When we think about CRRT, there's three main modalities that you have to choose from: CVVH, CVVHD, and CVVHDF. Most hospitals have machines that do at least two of these. The CRRT machines that we have only do CVVH, hemofiltration, and hemodialysis, the HD, but there are certainly plenty of hospitals and brands out there that do HDF, which is a combination of the two, hemodiafiltration. Also talk a little bit about AVVH, which is what we call our accelerated CVVH, sometimes also referred to as prolonged intermittent renal replacement therapy, or PERT. You don't see a lot of slow continuous ultrafiltration, which would be fluid removal without solvent clearance, mostly because the cardiology studies that were published in the early 2000s showed that appropriately dosed diuretics did just as well as isolated ultrafiltration in patients with advanced heart failure. And then if you're at a hospital that doesn't do CRRT and you can slow down regular dialysis machines to SLED, which is slow, low efficiency, sometimes daily dialysis, this somewhat serves the same purpose. This is the model I use in my talks about the kidney. So imagine that instead of the 1 million nephrons you have per kidney, you have just one. And so your blood is flowing from your aorta, somewhere in this top left corner of the slide, down to your renal artery, to your smaller arterioles, to your afferent with an A arteriole, down into the glomerulus, where anything that's small and charged and non-protein bound is freely filtered, and then blood returning with the efferent with an E arteriole back to the venous circulation. And of course, the elegant and wonderful part of the kidney is all this tubular reabsorption and all these mechanisms that allow us to keep the things your body needs and regulate what it doesn't and remove the rest in the urine. But of course, if you're anuric, we can do this with a filter extracorporeally through two venous ports in a venous circuit. Where the blood flows out of one port into the filter. Anything that's small, charged, non-protein bound gets nicely filtered and then returning blood to the patient. And then if you've ever noticed on the floor to these RRT machines, just like a regular hemo machines, there's a tube that's usually going into the sink or the toilet where all the ultrafiltrate and effluence goes. And so you must give these electrolytes back that you would normally reabsorb, of course. And so we can do that. You can do that in one of two ways. One is to give replacement fluid if you're doing a CVVH circuit post-filter, but in reality, most places do it pre-filter. This may seem counterintuitive from an engineering standpoint because you're now dialyzing some quote-unquote good solution, thus lowering your efficacy, but it also dilutes the fluid in the filter and lowers the risk of clotting. And I think that's a small price to pay with a modality that's already sort of inefficient by design. CVVH and compared to CVVHD has a different method of filtration. The method of filtration in CVVH is convection. It's basically reverse osmosis. So if you have all your solutes moving through one side of the membrane and on the other side is what you're pushing out with a pump, so pure water, solvents get dragged out as a result. Dialysis, of course, is the same way in intermittent hemo, where you have a diffusion gradient, so you're basically setting concentrations for all your electrolytes that you want to keep. So if your potassium is, say, 6 in the body, you might set a dialysate concentration of 2, and then have it pass in countercurrent directions, and then return the patient's blood with hopefully lower electrolytes and toxins than it started with. This is a prettier picture of what I had in a more basic Microsoft Paint era cartoon. It's just to remind that still the most recent sort of broad medicine New England Journal article is from 2012 by Ashita Talwani, has a nice sort of down to basics reading on CRRT if you're interested. It's still really good. It's written for like internists. So if you want like a little more deeper nephrology one, there's an AJKD sort of critical core curriculum from I think 2016 that I like as well. Those are two citations that I generally port people to. This one doesn't have some of the more recent dosing data in it, but still very good. I think when you really get down to it, CVVH and CRRT is quite simple. And when you think about what we set, there's only 3 settings on the machine for the most part, depending on what your kind of machine you're using. You've, of course, got to give either dialysate or replacement fluid back. That's the setting we tend to set by, weight-based dosing and based on the literature. There's a blood flow rate, and then there's the ultrafiltration rate, which is the amount that we set to remove on an hourly basis. And in general, it's the replacement fluid rate that is most important to dosing. You can see, though, why this might be better tolerated than a patient with regular blood flows of hemodialysis, which are much higher. And because the treatments are shorter, in order to achieve the same sort of daily net UF or net ultrafiltration, you need to run hemodialysis with a much higher goal. And this is why, functionally, like we all believe, CRRT is the better modality for patients on pressors. And of course, when would you use CVVH as opposed to HD? And again, it's the same answer as before. I wish there was like a set of numbers I could give you or something clear, but it's really the same indications you would for regular dialysis, and then something where you think the patient will tolerate a continuous modality better. Usually that's hemodynamic instability, but it doesn't have to be. Patients in advanced cardiac failure that are significantly volume overloaded and maybe aren't on pressors, you might think this is a better modality to get them more euvolemic more quickly. Of course, inputs are really important. So very commonly you'll get a patient who's post-operative and on high volume TPN, and you might not be able to keep up with that volume if they're just doing 3 times a week hemodialysis. So maybe that's another consideration. And then acidosis, I think we have a lot of discussions probably as nephrologists about treating acidosis, what's the right number to start dialysis. It is something that I think the literature is a little bit light on, but something that you can think about, because really CVVH, when it comes down to it, is a bicarbonate machine. You're sort of giving what I like to call consequence-free bicarb, where you're giving all the sodium bicarbonate through the dialysate or through the replacement fluid without the extra salt that you could give for pushing bicarb. There are some unique situations, particularly in patients at risk or having ongoing cerebral edema, such as liver failure or head trauma, where CVVH is indicated even in the presence of normotension, with some light evidence-based guidance. And so those are primarily in the neurologic ICUs. You might see a patient with a intracranial bleed after, but as ESRD, you might move them over to CVVH if you're worried about spread or after a severe trauma. The reason for that is because at least initially, the hemodynamic stability of CVVH is apparent, and especially in the beginning of dialysis when you're trying to keep the blood pressure stable. And by keeping the blood pressure stable, you're keeping cerebral perfusion pressure stable. And when you drop cerebral perfusion pressure, it does increase the risk of herniation. This mirrors the change in MAP, so we use that sort of as the surrogate for neurovascular protection in that regard. When you're finishing your course of CVVH, or say your patient's sort of gotten through that initial sort of decompensating period and now they're in a stability to improvement period in the ICU, you can certainly go right to HD once you're off pressors. We, not always, but often will transition to this intermittent modality. We call it AVVH, accelerated CVVH, where we found that when we were going directly to HD for these patients from CVVH, there was a very high bounce back to the ICU rate related to intermittent or interdialytic hypotension. And the thought is maybe if we get these patients a little more gradually graduated, if you will, and take off a little bit more fluid, but they might not need 24-hour renal replacement support, which is really what AVVH is a 10 or a 12-hour treatment that might serve them better. And we did see a reduction in our bounce back rate. And because replacement fluid is the most important part of the prescription, when you think about dose, I think about total liters per day when I'm dosing CVVH, for example. And so if I'm running a patient at a standard prescription of 1.6 liters an hour, and I run that for 24 hours a day, that's an intended target of 40 liters of replacement fluid per day. I can get that in a 10-hour period by running at 4 liters an hour. What the minimum amount of clearance a patient needs who's in steady state in the ICU is not really well defined, but we've found this particular approach has worked well. And you can even double down on your fluid removal rate per hour and remove twice as much fluid, which is a lot more gentle than removing, say, 500 or a liter in an hour, and achieve the same volume goals that way as well. So I think this is a nice modality, though not every patient needs it. When to stop renal replacement therapy remains a clinical judgment call. My general rule of thumb is if you're making 1,000 cc's of urine a day, this is the point where you might consider a dialysis holiday and see if you're clearing enough to make ends meet, so to speak. I'm often asking for a timed urine creatinine collection to measure clearance that way, because once you're coming off dialysis, the estimated GFR in the computer obviously is no good because creatinine is reduced by dialysis. Generally speaking, the chance of renal recovery is inversely proportional to how much CKD you had going into your ICU stay. So if you came in with normal kidneys and suffered a severe, pick your bad, out of hospital cardiac arrest and you wound up on ECMO, your chances of recovering your kidney function, even if you require dialysis, as long as you live through the event, is actually pretty good. But if you go in with CKD stage 4 or 5, the chances are markedly reduced down to about 50% or so. Regardless, though, any AKI we think that requires dialysis leaves patients with less reserve. So even if their creatinine normalizes, we view this as CKD stage 3 at least, and they should be followed by a nephrologist. There are a couple of reasons I steer away from CVVH, and when I say contraindication, some of this means we should probably think about intermittent dialysis even if the patient's on pressors, because the thing we want to remove needs to be removed more quickly. Most seriously, I would say, is a life-threatening hyperkalemia, where even if you're on pressors, if your potassium's 8 and you've got a sine wave, probably you want to try that patient on a couple hours at least of hemodialysis and then chase it with CVVH later to prevent rebound. Similarly, drug ingestions where you're motivated to get these out of the body quickly, particularly metformin and ethylene glycol probably are the most potent and most important to remove fast. Hemo is usually better. And then others, some degree, even if you're on pressors, you might want to at least start with some initial clearance and then again chase with CVVH afterwards if you're feeling like you still need to clear and you're a little nervous about the hemodynamics of the patient. And then I wrote the word futility here just because when you initiate renal replacement therapy in the ICU, it's a very tangible moment and usually a moment that something is going wrong. And it's easy to understand. So this usually is a good time to have a multidisciplinary discussion about the overall patient trajectory and what the goals of the patient and their family are and what the expectations of the medical or surgical team that's taking care of them is. Using it as a nice point to have sort of a revisit of goals of care, I think is a really nice point where we can inject ourselves into the care of the patient. So kind of to summarize, like when do you start CVVH? Well, we try to use data. You're trying to achieve what is best for the patient, and usually that is, getting appropriate intravascular filling pressures, controlling acidosis, making sure the lungs don't get too wet so you have prolonged intubation time. And again, the word trajectory comes off all the time in my head. If you spin the urine and it's nice and clear and you give a big dose of Lasix and the patient is polyuric, I don't really care as much if the BON is climbing, if the BON's 100. If we think we're going to get through this period without dialysis, I'm willing to give it a shot. But if you spin urine and you see dense muddy brown cast and you give 160 milligrams of Lasix and you're not getting any urine output, I'm not one to wait if the patient doesn't look like they're rapidly improving in other areas. I think there's plenty of evidence to support earlier renal replacement therapy in that population and allow for tighter volume control so you don't play catch up 24, 48, 72 hours later. With that, I can stop there and we can, I guess, pivot to Dr. Mount if there are questions.